name is Misty Hoschel. I'm a National Registered EMTP working for First Help of the Carolinas in Montgomery County. Been a paramedic for about 11 years now. Today we're going to cover seasonal emergencies. This program was set up to also have group presentations, small group sections where you went over different types of scenarios and how they worked out what we're covering today, as well as having a guest speaker from a local, I guess it's a specialty type area where he really deals with those types of animals that we're going to encounter during the season. Your venomous snakes, he actually has some crocodiles and alligators, and he will bring them in and work with you one-on-one with those. But today we're going to do just the lecture portion of the class. The spring and summer, especially here in the URI, brings new challenges to emergency care providers. You're going to start running into higher temperatures. Out here we do have two different lakes, Baden Lake, and we also have Lake Tillery. So you're going to have swimmers, divers, watercraft users. We're going to have increase in drownings or near drownings, watercraft accidents, diving injuries. We're also going to see an increase in those species of creatures that become more prevalent, and we're going to have that contact with them. So you're going to have your reptile, your arachnids, your bees, wasps. First, we're going to start out going over heat emergencies. Okay, so heat emergencies are caused during the summer by exposure to hot weather and sun. The old and very young are very prone to heat emergencies. You have three stages in those heat emergencies: heat cramps, heat exhaustion, and heat stroke. Your typical signs and symptoms with heat cramps, that's your milder signs. You're going to be normal to elevated body temperature. They're going to be warm, moist skin. They're going to have weakness, muscle cramps. Treatments are simple. Give them PO fluids as tolerated. Oral is always the best. If they can tolerate drinking fluids, let them drink that fluid. Monitor and reassess for the need for further interventions, including transport. Some of these patients may not want to go by ambulance. They may just want to go by car. Next stage, of course, is the heat exhaustion. Elevated body temperatures, cold or cool, moist skin. They're still going to be weak. They're going to start showing those anxiety signs and symptoms. They're going to be very tachypnic, higher heart rates. They're going to complain of headaches, dizziness. You might see nausea and vomiting, some dehydration. You're going to start seeing the mental status changes with these patients. The last stage of your heat exposure is the heat stroke. This is the most severe level. They're going to have a fever that's usually greater than 104 degrees Fahrenheit. Hot, dry skin. They are no longer sweating. This may not be the case when dealing with victims of exertional heat stroke. Those out there exercising, running, jogging, they may still have sweat on them. So hypotension, they're still going to be tachycardic. They are definitely going to be altered if they're still awake, or they could be in a coma. So the ones that you're going to treat the most aggressively are, of course, going to be the heat exhaustion and the heat stroke. Treatments are the same with either of those. Active cooling measures to maintain the temperature below 102.5. Try to keep them cooled down some, but don't be too aggressive to get them too far below that. You want to do a 12 lead on them. Watch for any kind of cardiac changes. IV, IO, give them some fluids. Saline bolus to keep their systolic blood pressure greater than 90. Establish an airway if needed. If they've gone unconscious, start looking at possible airway compromise. All right, so we've covered those people who have been out in the sun, who have been out running, doing activities, biking, exposed to the heat, the high temperatures, which here in North Carolina can be a little extreme sometime. So, I mean, we're going to see that. Now we're going to go to those who have been out swimming in the water. Maybe they're staying a little cooler, and this is how they're trying to keep cool. So, drowning is the process of experiencing respiratory impairment from submersion or immersion in liquid. It doesn't always have to happen in a body of water. We've seen people drown from a tablespoon of liquid. Drowning patient typically has 1 to 3 milliliters per kilogram of water in their lungs. It's not going to require suctioning. It's not a large amount. It doesn't take a large amount of water for someone to technically drown. Unless there's evidence of a trauma, spinal mobilization is not necessary. If there is evidence of a trauma, of course we're going to put them in full spinal mobilization, do everything like we normally would do for a trauma patient. Regardless of water temperature, resuscitate all patients with non-submersion of less than 25 minutes. So if they've been down for less than 25 minutes, go ahead and resuscitate them. Get ready for it. If submersion time is greater than an hour, let's consider moving to recovery instead of rescue. Those people probably are not going to be easy to resuscitate, so it's going to be easier just to do the recovery. All right, our next big problem that we're going to run into during the summer are all of our little critters that are going to start coming back out because it's gotten warm. There are thousands of creatures that produce and secrete venom in the U.S. of some form or another. Most do not have an effective method, though, of injecting them and spreading the venom into humans. The most commonly encountered venomous creatures are snakes, spiders, bees or wasps, and for those people who like to have those rare creatures, I mean, we're not going to see them much here in North Carolina, you're going to have your scorpions. One of the biggest causes of mortality from bites and envenomations is going to be your anaphylaxis. It can occur with exposure to any venom, but most commonly with that from the Hymenoptera, which is your bees and wasps. And it's mostly related to their bites or stings. Treatment of the anaphylaxis due to bites and envenomation is the same due to any cause, whether it be food, medication, any other cause, you're going to treat it all the same. Your epi, Cymedrol, Benadryl, follow your typical anaphylaxis protocol for that. Treatment for all envenomations that do not include anaphylaxis. So if you don't have the signs and symptoms of anaphylaxis, you're going to do airway, breathing, circulation management. So your typical ABC management. You're going to transport. Antivenoms are not commonly used in the pre-hospital setting in the U.S. unless you're in some random location where hospital settings are not, readily available. However, even in the hospital settings, it is hard here in the U.S. for us to get some of these antivenoms, especially if we go somewhere where somebody has some exotic pet and has gotten bit by it, like a cobra. That's a lot harder for us to get that antivenom here in the U.S. than it is somewhere where the cobra is more common. Attainment of vascular access with all transported patients, so get that IV, IO if necessary. And of course, before you even approach this patient, your primary concern is you make sure that scene is safe for you. That venomous creature could still be somewhere. So if that patient is not already moved away from it, you make sure that it's nowhere near where you're going to be because you don't want two patients. All right, one of the most common ones that we see is actually going to be, the Hymenoptera, which is honeybees, yellow jackets, wasps, hornets, fire ants. Estimated more than 1 million Hymenoptera stings annually in the U.S. Only 3% of them require transport for anaphylaxis. There is a degree of cross-reaction in the venom of all three subfamilies. I'm not allergic to bees. I am allergic to wasps. There is a chance I'll be allergic to fire ants if I ever get bit by them. So just because somebody says they're not allergic to one doesn't mean they're not allergic to something else, or that if they are allergic to one, they're not allergic to the other. A person who becomes anaphylactic after a bee sting could also become anaphylactic after a fire ant bite. The honeybee stings, the stinger venom sac is pulled from the bee and remains attached to the skin. So we're going to want to get that out. You're going to use a credit card, scrape it out, get the sac out because it's going to still keep putting that venom in there. All right, your assessment. Venom of Hymenoptera is a mixture of proteins that causes a local reaction with symptoms including erythema, so swelling, redness, and pruritus. Melatonin, a protein in the venom that causes the immediate pain from a sting. It works through direct effect on the skin's pain receptors. It hurts. The more severe Hymenoptera sting reactions are immunoglobulin E mutated. In a quarter of the stings, a local reaction develops. Anaphylaxis occurs rapidly, typically within 10 minutes, within 60 minutes for 95% of the time, rarely takes more than 4 hours. If there's no history of an allergic reaction to bee stings and no systemic reaction, transport is usually unnecessary. It advises the patient of anaphylaxis warning signs and the urgency of calling 911. Make sure they have a checkup with the physician if it doesn't improve within 24 hours. I mean, you're going to have a localized reaction typically, but it's not going to spread. Infection is likely after fire ant stings, however, about 6 hours after the sting. Treatment for these Hymenoptera stings typically focuses on pain and infection risk minimization. Determine if the stinger and venom sac are still attached to the skin, remove it as rapidly as possible. After the stinger removal, clean the wound thoroughly. Treat local reactions with cool compress and elevation. Antihistamines can be used for systemic treatment, and additional measurements for fire ant stings include moving the patient and crew away from the site. Like I said, always make sure your scene is secure. You don't want to become another patient. Make sure you brush the ants off. If you can't get them brushed off, hose them down with a water hose if it's available. Use whatever means you have necessary to get the ants off the patient. And always provide supportive care. Another common thing we're going to see, especially out here in the URA, are tick bites. They are everywhere in the woods. We're going to see them. Ticks are blood-sucking arthropods found in the world, often in rural wooded areas. Normally bites are not a medical emergency, but they can be a concern because they can cause diseases. They will transmit bacteria, viruses, protozoa. They're linked to a variety of serious illnesses, febrile illnesses, Lyme disease, Rocky Mountain spotted fever, things like that. And we need to be concerned when somebody does get bit by them. Rarely, a bite on the back of the head, neck, or spine may cause a potentially life-threatening tick paralysis that cannot be reversed until the tick is removed. In these cases, the presentation can present such as Guillain-Barré syndrome. So if the patient has an unexplained weakness after recently being in the woods, that could be one of your signs and symptoms that we need to be taking them to the hospital. All right, the principal treatment of a tick bite is getting the tick off the patient. You want to make sure that the tick does not leave its head embedded. You want to make sure you wear gloves, use curved forceps, pull straight upwards, do not twist, do not jerk, do not squeeze, do not crush its body, and make sure you dispose of it. In a container of alcohol is a great place to put it. Once the tick's removed, wash the bite with soap and water. There may be a reason to transport, but only if the patient is symptomatic. Advise the patient to see a physician if they are asymptomatic. If you suspect tick paralysis or Lyme disease, transport the patient immediately. My least favorite subject, spider bites. There are an estimated 34,000 species of spiders worldwide. Most are carnivores, can bite. 3 important spider species here in the U.S. the black widow, the brown recluse, and the hobo spider. Only the female black widow spiders are dangerous to humans. Names for the practice of devouring her mate. Identifying features is that she's glossy black with a 1/2 inch oval body. Her leg spans about 1.5 inches wide. And she has a characteristic orange or reddish hourglass mark on the abdomen. I see a black spider, I'm done. I'm not asking it to roll over so I can look at his belly. Sorry, just not doing it. is found throughout the U.S. Most of the 500 to 1,000 bites occurring in the U.S. happen between April and October, so we're coming up on that time. These type spiders, the black widows, like to make their home in sheds, basement, garages, wood piles, similar areas, so dark places, damp places. Used to like to live in outhouses, so you can imagine where those bites used to occur at. But now most bites are on the hands and the forearms from where people reach into things. North Carolina has a high occurrence of the brown recluse spider. It's also known as the fiddleback spider. You can also find them in the southern Midwest to Texas and of course across the Southeast. It is not found in the far west unless it accidentally gets transported there in moving boxes or on trucks. They are not aggressive, bites only when encountered. The hobo spider is a similar species to the brown recluse. They're the ones that's found in the Northwest. Their bites are very clinically similar to the brown recluse, but it's a slightly more aggressive spider. All right, as far as spider bites, history of the spider bite cannot always be confirmed. I mean, sometimes they wake up with it, sometimes they can't identify the spider. The patient may just report a sudden sharp prick followed by cramping, a numbing pain that begins at the bite and gradually spreads. Classic signs of black widow spider bite: extreme restlessness. And sometimes they just wake up with a sore. So we need to be concerned with a possible spider bite depending on where they were. Black widows are one of the most venomous North American spiders. So you're going to have some muscle spasms, some swelling, paralysis, local pain with rapid onset. That's usually going to set in about 30 to 60 minutes within the bite. Diffuse and more muscle spasms will follow. Nausea and vomiting will eventually set in. If the diaphragm is affected, respiratory difficulty may develop. The bites of the brown recluse are usually painless. Few or no subsequent symptoms, either local or systemic. Small subset of those will have pronounced symptoms and will develop a potentially fatal condition that begins with painful inflamed vesicles, may progress to gangrenous sloughing of the skin. Systemic symptoms are much rarer and they include nausea, vomiting, fever. Rarely hemolysis and coagulopathies have led to death. Treatment for the black widow spider bite includes intermittent use of ice, antimicrobial cleansing of the wound, providing pain and muscle spasm relief, and prompt transport. Get them to the hospital. Treatment for the brown recluse and the hobo spider bite is supportive. Antivenom is not routinely available for these bites. Dapsone has been recommended for brown recluse bites, but has recently been shown to be of really no benefit. People have even tried electric shock, steroids, hyperbaric oxygen, antihistamines, and early excision of the area to get the bite out and keep it from spreading. Standard ABCs and monitoring of the patient is a standard. Obtaining IV access and applying oxygen. Using narcotics and muscle relaxants and sedatives as needed. If antivenom is available, then the hospital can use it too. Scorpions are not very common here, but there are approximately 90 scorpion species in the U.S. And we do have some people who will keep them as pets, so it is still a possibility. The bark scorpion is the only one that's a potential threat to humans. The bark scorpion is found along the Mexican border of Arizona, California, with habitats up to parts of Nevada, New Mexico, and Utah. They are aggressive. They're not aggressive, but crawl into places like shoes. They're nocturnal. They climb walls where they can accidentally fall on you or be encountered otherwise. Venom is a mixture of many toxins that affect nearly every body system. The local stings are similar to Hymenoptera stings, with erythema, pruritus, urticaria, sharp burning pain, paresthesia, reported as a feeling of a strong electric shock. All right, so the symptoms are going to depend on which part of the nervous system gets affected. So the sympathetic stimulation system symptoms include tachycardia, palpitations, tachypnea, hypertension, dry mouth, elevated temperature, sympathetically induced pulmonary edema. Then you have your parasympathetic stimulation, which includes bradycardia, hypotension, lacrimation, salivation, urination, defecation, cranial nerve findings, priapism. You have all these lovely side effects that could happen. Then you're going to have somatic involvement symptoms. So muscle contractions, myoclonic jerking, fasciculations. The typical victim of a scorpion sting is going to have nystagmus, hyperventilation, they're going to breathe fast, dysphagia, mydriasis, restlessness. Our treatment of this patient: ABC maintenance. You're going to monitor them, transport them, intubate them if it's necessary. IV line, IO, whichever one is going to work for you. You're going to give volumes of fluid to keep their blood pressure up above 90 systolic. Ice pack application is necessary for localized pain. If seizures are occurring, you're going to treat it with benzos, and then you're going to transport. A patient with a bark scorpion sting may show signs of severe toxicity. The last thing we're going to cover is snake bites. North Carolina has several snakes, and we're coming up in that season where here in the URI you're going to have hikers who are going to encounter some of these. There are 2 families of snakes in the U.S. of concern for envenomation, and of those 2 we have a couple. Approximately 10,000 snake bites in the U.S. every year. Only 2,000 present for actual treatment. Bites are most commonly seen in the southeastern U.S., with Texas having the greatest number of recorded snake fatalities. Wonder why? Pit viper venom contains both hemolytic and proteolytic enzymes that cause extensive local tissue damage and systemic effects, causing soft tissue swelling and necrosis, local then systemic bleeding, and clotting problems. Coral snakes are elapids. 3 main coral snakes are found in North America: the eastern coral snake, the Texas coral snake, the Sonoran coral snake. Bet you can't guess which one we have: the eastern coral snake. In the continental U.S., the elapid can be described by its banding pattern: red on yellow, kill a fellow, red on black, venom black. It's difficult for coral snakes to inject venom because their fangs are very small. Snake must stay attached to cause envenomation, so handlers are most typically the ones bitten. It may take several hours before systemic symptoms develop. Any patient with possible elapid bites should be transported. Envenomation causes few local symptoms, but they have potent neurotoxic venom, which can cause paresthesia, fasciculations, weakness, respiratory difficulty, and stroke-like symptoms. Then they're going to have local tissue injury. Our pit vipers: see, rattlesnakes, cottonmouths, copperheads. Causes of the greatest number of bites and morbidity. The name is derived from the heat-sensing pits located beneath the eyes and the nostrils. These snakes are all over the Carolinas. The eastern and western diamondbacks cause the greatest morbidity and mortality. When you go in to assess your patient, number one thing is your safety above and beyond. You can't treat if you also get bit. Be certain the scene is safe and the snake is still not a threat by confirming it isn't either dead, trapped, or gone. Note the time of the bite. Important to know the amount of time that passes from the bite to the time of the care. If possible, determine the type of snake. Do not go looking for. Dead snakes can still bite. They can still move, and they will still bite. So, choroidal venom mixture of enzymes that promote tissue destruction through proteolysis, hemolysis, thrombogenesis, some degree of neurologic and cardiac toxicity in higher doses. So venom components can cause signs and symptoms of a toxicity. Severity is determined by the amount of venom injected and the location. It's difficult to determine immediately, so transport all patients. Up to 25% of your bites do not have venom injected, called dry bites. Elapid venom is primarily neurotoxin that leads to respiratory failure and death. So for the choroidal bite symptoms, we're talking swelling and pain at the bite site, bleeding. As severity increases, you're going to see swelling progressing up the extremity. Systemic symptoms will occur with abnormal taste in the mouth, weakness, altered mental status, diaphoresis, nausea, vomiting, dizziness, unconsciousness, tachycardia, shock, and cardiovascular collapse. So the degree of the envenomation determined by the degree of swelling and presence of systemic symptoms. So you got mild, moderate, and severe. Mild, minimal local swelling with no systemic symptoms. Moderate, swelling's extending up the extremity, presence of systemic symptoms. Severe, extensive soft tissue swelling, severe systemic effects, and bleeding, and up to intravascular coagulation, shock, or coagulation abnormalities. Treatment. It's actually antivenom. Monitoring ABCs. Clean the wound. If your county does it or your system does it, draw blood for hospital use, because the blood obtained later may produce unreliable coagulation studies as the venom breaks things down. Immobilize the involved extremity in a neutral position below the level of the heart. Do not apply excessive constriction. So, not really a tourniquet. Remove rings and other constricting jewelry, because sweat and swelling as it occurs rapidly can actually cause the constriction with the ring, and you won't be able to get it off, and they'll have to be cutting it off. Begin immediate transport to a facility where the patient will receive that antivenom. So, any questions? None? Okay. So what we covered was pretty much all of the environmental things we're going to come up with during our lovely change of seasons here as we start moving into spring and summer. Heat emergencies, as we start seeing heat cramps, heat exhaustion, and heat stroke. Drownings and near drownings. We also covered snake bites and other envenomations with bee stings and scorpion bites. And if there's no other questions, then we'll conclude our presentation today. Thank you. Okay, so what we're going to show now is this is a snake bite wound, and you can see where we have some swelling noted. One thing I do whenever I have swelling is I like to mark the outline bits and pieces of it so I can kind of see where the patient swelling is currently at, and I can keep an eye on it to see if it's getting worse. And as you can see, we go back and check a little bit later, and the swelling has now gone well beyond our original circle. If we had a long transport, we would remark again so we can see if it gets more swelling as the time goes on.
I'm consenting.
All right, so now whenever we have an injury like this, one good thing that it does show is going through and splinting the arm at a level below the heart. One good thing to do is a triangle bandage. We want to tie a knot in it to make an area for the elbow, at which point in time you'll put the elbow in that knot, lower the wound below the level of the heart. You will secure it with a simple tie behind the patient's neck to secure it in place. The good thing about this type of splint for that injury is that it does also provide us a way to put ice on the wound which you do want to wrap into a plastic wrap, inside a towel, and then you can put it right inside the splint on the place of injury to provide some cooling and to keep the swelling down during transport.